All right, so changing gears a little bit, let's jump into CAT scans.
Let's do.
All right, so we're going to start with chest CTs. And as I like to affectionately say, why isn't that darn radiologist calling me back? So our goals today, we're going to talk about a practical method for reviewing emergency CT scans of the chest. We're going to talk about some of the common findings in life-threatening CT diagnoses and talk about some of the common pitfalls. We're focusing on emergencies here, all right? What we're not going to be doing is focusing on teaching you how to diagnose interstitial lung disease. We're not going to talk about evaluating pulmonary nodules. We're really focusing on the big, bad, scary things here.
The stuff you need to know before the read comes back.
Exactly, like when to hit the panic button. So how do we read these things? So this is going to be a bit of a departure from my usual spiel. So we're not going to focus on things like the ABCs because they just don't work well for this. What I want you to do, though, is still be systematic. And with this system, we're going to look at see what's going to kill them first.
Okay, makes sense.
We're emergency doctors, you know, we focus on the catastrophes. So let's start with what's going to kill them first. And in the chest, that's going to be the aorta.
Absolutely.
So when we look at the aorta, we're going to look at things like size. You know, is it too big? Is it irregular? What's the shape? What's the contour? What's the lumen look like, importantly? Next, we're going to look at the heart because that will also kill you quick. So we're going to look at chamber size. Are things too big? We're going to look for things like pericardial effusions. And then we're going to move on to the pulmonary vasculature because that can also kill you pretty quickly. And so we're going to really focus on the pulmonary arteries, looking for things like pulmonary embolism. And then we're going to move on to the lungs, look for things, you know, like big pneumothoraces, et cetera. We're going to look for consolidations. We're going to look for contusions. We'll look for some masses. That's probably not going to kill them quick, but, and then things like pneumothoraces. So, and then we're going to finish up with the bones.
Okay.
And you got to be systematic with these and you got to be thorough, especially the ribs. Rib fractures, even on CAT scan, can be tough. And I recommend checking them even in the absence of trauma. So someone comes in with chest pain, it's not at all uncommon to have stress fractures there. You think about some of these old osteoporotic patients, you know, they're hacking, they're coughing, they can easily crack a rib. And then you got to worry about things like pathologic rib fractures as well. So I definitely recommend checking out the bones. Who needs contrast? So this comes up all the time. Who do I need to give contrast to for the CT of the chest? So things sort of make sense. For vascular things, you're going to want contrast on board. For trauma, you're going to want contrast on board, particularly if you're worried about things like a blunt aortic injury. When you don't need contrast, so if you're just looking for things like pneumonias, like you have a funky looking chest x-ray and you're like, oh, is that a pneumonia? Is that a mass? You don't really need contrast for that. Things like masses, you don't really need contrast for. And for the bones, so if all you're worried about are rib fractures, say you have like an old person, an elderly patient who comes in with bad chest pain after like a ground level fall, you're not really worried about an aortic injury, you don't necessarily need contrast for that. All right, let's jump into some cases. So with these cases, I'm going to try and give you a lot of slices. Like I hate going to a talk and they'll be like, here's the pathology, and they give you just the money shot. I really want to go through some of these CTs in detail to sort of give you that experience of having to look at it yourself. So get ready.
I'm ready.
All right. So here we go. This guy comes in with chest pain. He doesn't look great.
Okay.
So automatically, you know, your spidey sense is going off.
I'll tell you, I already don't like what I'm seeing, but keep going.
Yeah. Yeah. So focusing on the aorta, not great.
That's certainly a dissection right there.
Yeah, that's a big old dissection. Even starting at the top, you said you didn't like some of what we were seeing, and I agree. So even up here at the top, we're seeing our great vessels coming off, and already I'm seeing some lumen issues going on here. So this dissection not only, you know, is involving the arch, but it's involving the great vessels as well. And certainly as we go down, we start to see a big intimal flap sort of just swaying in the breeze here. And so it just keeps going and going and going and going. This was an unfortunate patient with Marfan's. And he came in screaming his head off and really just hemorrhaging out of his GI tract. Severe abdominal pain, severe chest pain. And as you look, that, it just keeps going on and on. And so obviously we're talking about an aortic dissection here. What are we looking for? So ideally, we're looking for an intimal flap, and very often you're going to see two different lumens. You're going to see a true lumen and a false lumen. It's sometimes hard to tell the difference, honestly,
Absolutely.
between which is which. And I don't really expect us to make that distinction all the time. But just know that one of them is going to be true, one of them is going to be false. Interestingly, like in this case, the false lumen is thrombosed and not perfusing, but sometimes it's the opposite. So sometimes you're actually perfusing through the false lumen, which is terrifying. Other things that we want to look for when we see this, you want to look carefully for signs of things like complications, like a pericardial effusion. There's a big one there. There's a more subtle one right here. These are life-threatening. If they rupture through the aortic root and into the pericardium, they very rapidly can develop tamponade and die.
Absolutely.
Time matters. This is obviously a very high-risk injury. The clock is really ticking, so the mortality increases 1% to 2% per hour. So big numbers here. Other questions that we want to look for on this, because it's really going to influence who we call, is what type is it? And so there's different classification systems out there. The old one is the DeBakey scheme. Most people have pretty much gotten away from that because it was a little bit confusing. Nowadays, most people, including the surgeons, use the Stanford classification. It's pretty simple, Stanford type A or type B. And the reason why it matters is the management's different. So for Stanford type A, you know this, most of them go for surgical management emergently. For type Bs, most of them start with medical management initially, unless there's significant end organ involvement. And by that, I mean things like the gut. Kidneys, somewhat. You can live without the kidney. You can live without a kidney. So if it's just one involvement, they're not going to rush that patient off to surgery necessarily. But things like the gut, you sort of need that. So, but that's the big dichotomy there. So then the question is, how do we decide A versus B? And I've been involved in some very heated conversations with surgeons trying to decide, is this a Stanford A or a Stanford type B? Anatomically, the cutoff that we use is the takeoff of the left subclavian. So here's, our great vessels. Here's the left common carotid. There's the left subclavian. So if it's proximal to that, it's a type A. Goes to surgery. If it's distal to the takeoff here, it's a type B. There is this entity of an isolated arch dissection, and some people refer to it as a non-A, non-B dissection, but that's really beyond our scope. I'm still going to call the cardiothoracic surgeons on that. So again, takeoff of the left subclavian is sort of the cut point there. Okay, so here we see, this is a classic type A. So here's the aortic root. We see definite involvement there. We're seeing distal involvement as well, but this proximal involvement is what makes it an A. Moving down a little bit, here's a type B. So here is the takeoff of the left subclavian, and the flap starts distal to that. So this is a type B. So this was medically managed initially. Very interesting. DeBakey was a cardiothoracic surgeon who, obviously described aortic dissection. He developed the technique for repairing it. Do you know what Dr. DeBakey had in his late 90s?
Did he have an aortic dissection?
He actually had an aortic dissection. And he did not want anything done. And his wife evidently overturned it. And he underwent his own surgery in his late 90s and survived for another couple of years.
You're full of these interesting facts.
I love medical history. Yeah, it's fascinating. So yeah, we owe a lot to Dr. DeBakey. So when you order a dissection study, what are you getting?
Well, you're certainly getting the arterial phase timed at the aorta, right?
Yeah, so you're getting that arterial phase.
Okay.
But you're actually, in most institutions, you're getting 2 scans.
Oh.
Which is kind of crazy. And the first one that you get is actually a non-con study.
Okay.
It's a non-con chest, abdomen, pelvis, down through the bifurcation. So why in the world would we get a non-con study when we're looking at a vascular issue?
I'm very much so hoping you're going to tell me.
I am going to actually tell you. Yeah, it sounds very weird, very counterintuitive, right? But the reason why we do it is we're looking for this, which is an intramural hematoma, or an
Okay.
IMH. And what that is it's in the dissection spectrum, and it's blood contained within the media.
Okay.
And there are differing hypotheses as to where this comes from. A lot of people think it's from a ruptured vasovasorum, which is the blood supplied to the aortic wall itself.
Okay.
Other people think it's just a small flap that we're not seeing.
Okay.
But the reality of it is we treat it like a dissection.
Okay.
It shows up very often as this hyperdensity within the wall.
Okay.
This one's actually a fairly decent sized one. This is a non-con study, and we're seeing this bright blood here in the wall. The problem is when you bolus them with arterial contrast, that bright contrast can obscure that IMH, that intramural hematoma. Very much like when you have an acute subdural sitting up against bone, they can sort of merge together. The same thing happens here.
Okay.
So we do the non-con to look specifically for this intramural hematoma.
Interesting. Okay.
I used to think they were fairly rare, and I think I've seen at least 8 or 9 this year alone.
Oh, wow.
So they're definitely out there. And again, we treat them like a dissection. Okay. The second part is a full arterial phase study, and it goes all the way from the top of the arch and the great vessels all the way down through the groin. And obviously here, pretty devastating dissection, tore all the way down. And it allows you to really evaluate the full extent. It allows you to evaluate what organs are involved. And then the other reason why it goes all the way down is it helps the vascular surgeons decide what their operative approach is going to be, how they're going to plan their bypass.
Imagine, yeah.
So it's fascinating to watch them plan out what their approach is going to be. Where are they going to be able to get bypass points and stuff? So that's why we do the full CTA all the way down. You got to watch out for fake outs, and a lot of type A's start at the root, the aortic root. And if you look, like on this scan, you see what looks for all the world like it could be a dissection flap.
It's not?
It is not, actually. But this is a super common fake out, because what's happening is we're taking a static image of a moving structure.
Okay.
And when that happens, you get motion artifact, and it's typically from the aortic valve.
Yeah.
And so, unlike with a PE study, you can tell someone to take a deep breath, and you get a static image of their lungs.
You can't tell people to hold their heart.
You can't really tell people to hold their heart. That doesn't work so well. And so that's a common fake out. And I've been part of this discussion before. And so one way around that, and this is not something you're going to get routinely, but in these cases where you're suspicious and your initial CTA is equivocal, you see that maybe a flap, maybe artifact. One thing that you can do is you can get an EKG gated study. Have you heard of this?
This is when they time it with the heart motion, correct?
Yeah, so it's fascinating technology. So basically they take the patient and they use EKG leads and hook them up to the CT table. And what it then does is it acquires images at the same point in the cardiac cycle based on their EKG.
That's crazy.
And then the computer, through the magic of science, squishes them all together and creates a very clean image that really essentially eliminates motion artifact.
That's awesome.
This is the technique that they do when they're doing coronary CTs.
Okay.
Which sort of makes sense. You need a very still image to look at those. And so they do gated studies.
Okay.
Again, it's a little labor intensive. It's not something you're going to be routinely ordering on everyone, but it can be really helpful to decide, are we going to crack this patient's chest open or not in these equivocal cases? And you can see just how nice and crisp and clean, like there's the aortic valve in full glory right there.
Is this something you're going to order after you get a CTA?
Usually, yes.
To like confirm or exclude? Okay.
Yeah, it's not something, at least in most institutions, it's not something that you're going to be ordering up front as your initial study. Caveats to that, because it's picking out images from the same point in the cardiac cycle, you need to have a regular EKG.
Okay.
Okay, and so in someone who has an underlying arrhythmia like AFib, a flutter, or if they're just having frequent ectopy, so if they're having like bigeminy or just a ton of frequent PVCs, it's not going to work very well.
Makes it challenging.
So that's one limitation to it.
Okay.
Okay. This one comes in, 72-year-old with chest pain, a little bit of shortness of breath. We're going to start to come down. So a few things that stick out at me as we're sort of scrolling through. She doesn't have the healthiest aorta.
No.
You know, there's definitely some vascular disease in there. There's some aortic plaque in here as well. So not the healthiest specimen in the world, but we're coming down, we're coming down. Looks pretty good.
Mm-hmm.
And then as we start to get further out into like her pulmonary vasculature, I start to see something.
Yeah. What's that?
And then as we come down a little bit more, I start to see there's a little bit of schmutz down at the right base, down in here. So let's sort of take a closer look at that. And so this is actually a pulmonary embolism.
Okay.
And so right here, you see this little intraluminal filling defect here. So you see a little bit of dark in the lumen and then a little bit of squeak of contrast getting around it. So this is pretty classic for, you know, a PE. It's a little farther out. It's a segmental PE. So it's a filling defect in a segmental artery. And then that little schmutz we were seeing down here, right there, that's a Hampton's hump. Okay, so that's that wedge-shaped area of pulmonary infarction and inflammation distal to the PE.
Okay.
Okay, so doesn't look that bad, right? Like, looks like pretty small. It's isolated segmental, a little bit of pulmonary infarction, but probably not doing too bad. In contrast to this one, stop me when you see something.
I see a lot of something there.
Yeah. Wah, wah, wah. Yeah. So even at the very start, you know, if we come back up and look at this, what the heck is going on? Like, look at their SVC right there, right? You can sometimes get swirling of contrast that can look almost like a filling defect, but that's really organized and really central. And then as we come down, you start to see all these filling defects here, sort of in the left main, right main, sort of crossing over. So this is the granddaddy of all saddle emboli. And then they just keep going. They're everywhere. You can see them out here, you can see them up here, you can see them out here. So this is a massive PE. So we've identified the PE, then there's some other questions that we want to ask. And in particular, we want to look for things like right heart strain. And so as we continue down, anything else that sort of jumps out at you.
That RV is pretty big.
That RV is massive. It's as big as my head, right? Compared to that little tiny LV, really should be the opposite, right? And so something bad's going on there. And then as we continue to go down, we're scrolling down, scrolling down, scrolling down. Then we start to see all this stuff down here, which is all contrast, which on this phase of study really doesn't belong in the IVC and the liver, right? So everything's sort of starting to get backed up. So this is really, really a little scary, right? So this is your reaction when you're looking at the CT. So this is a saddle embolus, big filling defects bilaterally crossing over. And so once we identify PE, the next thing that we want to do is look for signs of right heart strain. And on CT, there's a few of them that we look for. One of them is this reflux of contrast. This is really bad. Not only is it back down into the IVC, but it's all the way out back into the liver as well. What this is telling us is that there's right heart strain and that there's, you know, increased filling pressure backing stuff up on the right side. It's not specific for PE. And so anything that causes increased right-sided filling pressures are going to cause this. Probably most commonly is increased left-sided filling pressure. So left heart failure causing right heart failure. Things like bad pulmonary hypertension can cause this. So it's not specific for PE, but when you see it in the setting of PE, it's really worrisome.
I got you.
Other things that we look at the size of the heart chambers. And so we look for things like septal bowing. So remember, your heart is essentially an LV, a big, thick-walled, strong LV, high-pressure system with an RV tacked on the side, thin-walled, low-pressure system, right? Here, and as you know, as the heart beats, your septum, you know, sort of squeezes in, but it shouldn't bow in. And what we're seeing here is that septum is actively bowing in. And in the setting of this hugely dilated right side, that's telling me these pressures on this side are way too high. They're physically pushing this huge, thick muscle in, and that's not great.
No.
CT has been accused of overestimating this. And it sort of makes sense because, again, we're catching a static image of a moving structure. And so there's some thought that maybe we're just catching it in some parts asystole and we're maybe overestimating this. So echo is a much better test to dynamically assess this. And that's what we would always recommend. But this sort of gives you some clues that there's probably some elevated right-sided pressures. And then we look at the actual size compared to the left. And so they talk about the right ventricular diameter compared to the left, and it should be about a 1-to-1 ratio.
Okay.
And so or less, once you see that the right to left ratio is greater than 1, that's predictive of right heart strain. They talk about measuring this with like a fancy 4-chamber reconstruction view. They've done some studies though that show that even just your regular axial views are probably sufficient to look for this, and it's still predictive.
Yeah.
If you see this, you're still probably going to want to get a formal echo to look for signs of right heart strain. Time is critical in this. Again, this is a big, especially these big ones, this is a killer. And so the majority of deaths are going to occur in the first couple hours of treatment. So,
and I think I feel like I don't have a hard time seeing those saddle PEs.
Yeah.
Those are far more rare. But once you get into segmental and subsegmental, I mean, I really have trouble seeing them. I have to scroll through a million times, and I'm missing most of them, I'll be honest.
And, you know, I teach this a lot, obviously. And the reaction I always get is hands throw up, and they're like, yeah, I just can't read these, you know, and it's just inevitable. It's the same, or, you know, And I think it's because people just get overwhelmed.
Yeah.
And it's because you're trying to look at too much at once. And so I'm going to walk you through how I do it.
Let's do it.
So the first thing I do is I drop the contrast down, the brightness and the contrast. Because when you open this, it's like big, flashy, in your face, like almost blinding, right? And so what I find is that when you drop that brightness and contrast down, it makes it a lot easier to pick out filling defects. So here I drop it down a little bit, and you can see maybe a little hint of something over here, but a lot more obvious now that I drop that contrast down. So that's the first thing that I do. And then moving on is when I actually start to look at the pulmonary vasculature itself. In my method, it really takes 4 passes to look for a PE. And so our starting point is going to be here. And so here are our right and left main pulmonary arteries. And this is where we're going to keep coming back to. And like I said, it really takes 4 passes. And so I start by tracing out the pulmonary artery down through the right lower lobe, come back, right upper lobe, come back, left lower lobe, come back, left upper lobe. And it is a little bit tedious. It takes a little bit of time, but it really allows me to focus my attention on just a small area and not get distracted by everything else that's going on.
There's a lot on the screen, so.
And there's a lot on the screen, and that's what I think overwhelms people. The next thing is, if you see something that looks like a filling defect, what you want to do is then trace it back and see, does it actually connect into the pulmonary artery, or is it actually in the pulmonary vein? And so here, if we look, there's what looks like a little intraluminal filling defect, looks for all the world like it could be a PE. But if you trace that back, it connects up into this vessel here, which is sitting next to the pulmonary artery. And it's actually the pulmonary vein. And what happens here, and why this is a common fake out, is you get swirling of contrast in the pulmonary veins, and it can look for all the world like a PE, like a filling defect. And I've gone running back to radiology multiple times, and they're like, yeah, settle down. It's not a PE. So common fake out, so just make sure you trace it back to the arterial side. All right, switching gears a little bit, moving into some trauma cases. This person comes in, high-speed MVA. Obviously some obvious external trauma. We're worried about this patient, so we get a CT. As we're starting to go through, let me know when you start to see anything. Yeah, something right there. A little bit more further down. So again, we're going to focus on what's going to kill him first. Looking at the aorta, you start to see maybe a little intimal flap there, and then you see this weird sort of contour out here. It looks almost like a mushroom on top. And that's consistent with a pseudoaneurysm. All right, so what we're dealing with here is a blunt aortic injury or an aortic transection. And sort of the classic mechanism that we're all taught is a sudden high-speed deceleration injury. And the thought is that your aorta is actually fairly mobile, except for a few points of fixation. And at those points, with the sudden deceleration, you get a shearing effect and tears the aorta. They've done some interesting studies, though. In particular, there was an autopsy study that looked at on-scene fatalities from car accidents. And what they found was that in those who died on scene, the vast majority had a T-bone component to it.
Okay.
And they think that with that, there's a sudden compressive force that causes this vertical shearing. And they think that that highly contributes to a transection type mechanism. So I put a lot of stock in like a T-bone type mechanism, and that just heightens my suspicion for something like this.
Okay.
Looking at sort of a diagram here, this is the sort of classic point of fixation here. It's right after the takeoff of the left subclavian, and that's at the ligamentum arteriosum, and that's where the ductus scars down and provides a point of fixation. Another place where you can see this happen is as the aorta goes through the diaphragmatic hiatus. That's also a point of fixation. Looking at some more examples, this one's pretty bad. So you see a pretty obvious tear there with pseudoaneurysm, and then you see all this soft tissue density up in here, and that's all mediastinal hematoma, which also commonly occurs with this. And that honestly is what commonly contributes to that widened mediastinum we see on X-ray. Looking at a couple more examples, here's one. Looks almost like a dissection.
Yeah.
But in this case, it's a traumatic transection with pseudoaneurysm. But if you look at the caliber of that aorta, it looks not all that abnormal.
No, not really.
And so when we talk about plain film findings, this is why you can have a normal plain film. All right.
I think something that stands out, and especially on the case, so it was a little more subtle, but normally the caliber or the aorta itself is quite round and consistent. And all of these, it's quite irregular.
Yeah, there's some little irregularity at least around it. So yeah, definitely catches your eye, something to watch out for. Here's our classic chest X-ray for blunt aortic injury. This one has pretty much all the findings. So widened mediastinum, loss of the aortic knob, loss of that AP window. There's a pleural effusion. You can see the left lung is hazier than the right. Has an apical cap, this density up here in the top. That's a localized effusion. Tracheal deviation, left main stem depression. So a lot of the classic plain film findings. But again, that scary statistic that up to 10% can be normal. So if you're worried about it, if they have a mechanism that would, suggest it, definitely get the CT.
Okay.
Here's another trauma case. Some obvious blunt truss trauma.
Aorta looks okay, but those rib fractures are concerning there.
Yeah. So multiple displaced rib fractures. You see a little bit of thickening down here, which, in this setting is probably a small hemothorax. Why do we care about these? We care about them more than radiology cares about them. And so looking at the ACR appropriateness criteria, they really downplay the importance of rib fractures. And that, I think, has translated over to the radiology side because they miss these all the time. And I've actually gone and done grand rounds for our radiologists. And we were sort of talking about differences amongst our cultures and our priorities. And I started talking about rib fractures, and they kept saying, why do you guys care so much about the rib fractures? You guys don't do anything with them anyway. And that's absolutely not true. Here we see them, they're super common, up to 10% of traumatic injuries. Almost 40% of patients with severe non-penetrating trauma are going to have rib fractures. So high numbers. And it turns out that the morbidity and mortality is actually quite high. We talked about this during chest x-rays, but at 45 and older with more than 4 rib fractures, your increased ventilator time, increased ICU time, increased hospital length of stay time. In older people, it's even worse. So age 65 or older, it's really going to have big impacts. And the main mechanism is fall from standing, like ground level falls. So with that age group, 2 or more rib fractures, twice the mortality of a younger person with the same exact injuries. And then for every rib fracture on top of that, your mortality increases by almost 20% and your risk of pneumonia goes up by almost 30%. So we're talking big numbers here. Assume the radiologist is going to miss them. They do it all the time. And again, not to knock them, but this is something that we should be looking for.
Absolutely.
Here's a fairly non-displaced one. These can be really subtle. Here's a little bit more displaced one. When you see these big hemothoraces like this, you definitely probably want contrast on board. And when you do, you see these sort of hyperintense areas in here. That's arterial extravasation, probably from a lacerated intercostal muscle. These patients can get into real trouble with that. So these are people that you want to get interventional radiology on board with.
Makes sense.
All right, so switching gears a little bit out of the trauma realm, This gentleman comes in, pretty bad chest pain after vomiting.
Okay.
What do you think?
Actually, it doesn't look that bad.
It really doesn't,
Yeah,
right?
no.
If you look real closely at this, you see that there are some subtle lucencies up in the soft tissues,
Yeah.
up in the neck, up in the soft tissues. That's pretty concerning for pneumomediastinum. And so now we have a gentleman with pneumomediastinum after vomiting.
Yeah.
All right, so alarm bells are starting to go off.
Absolutely.
We're going to scan this guy. And as we do, already you can see lots of pneumomediastinum up in the neck, all these air densities. And as we sort of come down, even more, you know, this is all mediastinal air in here. And then it really just goes all the way down. And there you can see esophagus down here is even outlined in air. Big pleural effusions bilaterally, which tends to happen with this. There you can see the esophagus just totally outlined in air. So this is Boerhaave or esophageal perforation. Very common to see pleural effusions, left more than right. The vast majority of these happen at the left lower esophagus. And so when you see changes like this, very often they're going to start to be left-sided. You see that extraluminal air. Here's another case where we see just a lot of mediastinal edema and fluid with some extraluminal air in there. So we actually have a CT esophageal perf protocol that most institutions have adopted. In the old days, if you were worried about an esophageal perf, so you had someone with pneumomediastinum, maybe there was some vomiting involved, you would get a swallow study essentially, so a fluoroscopic study. This CT esophageal perf protocol has supplanted that in most institutions. And it's really helpful. So basically what they do is it's an IV contrast and a PO contrast study, but they have the patient drink the contrast on the table essentially. And they're looking for extravasation. So it's not a prolonged prep. They don't have to drink it like 3 hours before. So they're drinking it literally as they're getting scanned. And in this case, you know, you can see a little bit of contrast extravasating out into the soft tissues. It's also nice, you know, it gives you the added benefit of giving you a look at the rest of the mediastinum, the lungs, that a fluoroscopic study is not going to get you. So again, any sort of pneumomediastinum with vomiting or with a pleural effusion is going to be Boerhaave's until proven otherwise. Here's another case. We saw this, I think, in the chest x-ray lecture. You see these weird sort of little blips of air down in here, probably a left-sided pleural effusion because we're not able to see that left hemidiaphragm. And again, just a massive perf, big pleural effusion. So untreated mediastinitis is almost fatal. So again, suspect it in your alcoholics who come in vomiting, heavily associated with alcohol intake. So 40% of patients with Boerhaave's are going to have alcohol on board. So, all right, so bringing it home, focus on what's going to kill them first. You know, start with the aorta, the pulmonary vasculature, move on to things like the lungs, the bones. Remember, in the CTA, the chest for dissection, look for that intramural hematoma. And then break up your CT studies into quadrants. It just makes it much more manageable, less overwhelming. And then first thing you want to do is damp that contrast down. And again, pay careful attention to the bones, just to assume that they're going to miss the rib fractures. And then esophageal perf studies, X-ray can be super subtle. All right, I'm not saying you need to scan every person who vomits. Please don't do that, but have a high index of suspicion. All right, and then any pneumomediastinum with vomiting or pleural effusion, you should be getting either an esophageal perforation scan, or if you don't have it, then at least, you know, either gastrographin or a barium swallow.
Thanks.